Good afternoon, everyone. Welcome to this IRPP webinar on improving prescription drug safety for Canadian seniors. My name is France Saint-Hilaire. I'm the Vice President Research at the Institute for Research on Public Policy in Montreal. For those not familiar with the IRPP, it is an independent, bilingual, nonprofit organization that was founded in 1972. And our mission is to improve public policy in Canada by generating research, providing insight, and sparking debate on current and emerging issues facing Canadians and their governments. This event is part of our Faces of Aging program, which for the past several years has provided new research on policy issues related to home care, long-term care, pharmacare, caregiving, pension reform, and age-friendly communities. Our publications are available free of charge on our website at irpp.org. The topic for today's discussion is evidently one that resonates broadly across the country. I'm pleased to say that we have online participants from all 10 provinces and 2 territories, from provincial and the federal governments, the health sector, associations of health professionals, universities, and several NGOs. Just to give you an idea, we did a little survey before we started here, and we have 11% participation from Atlantic Canada, 14% from Western Canada, Eastern Canada 71%, and the territories 3%. And we're very glad to have all of you taking part, since you all have something very important to contribute to this important conversation. The topic is also clearly on the federal government's radar. Just last month, Health Canada issued a backgrounder announcing that the government was taking action and providing new funding to improve appropriate prescribing and use of prescription drugs. Health Canada will be working with partners and stakeholders to develop policies and tools for appropriate prescribing, including by identifying best practices, supporting existing initiatives, and promoting new implementation strategies. We're going to begin with our panelist presentations today. Each presenter will speak for 10 minutes, after which we will take questions from the audience. Of course, participants are invited to send their questions in advance. Just use the chat line function on our website. And please indicate the person to whom the question is addressed. So it's my pleasure to introduce our panelists. We have Nicole Bernier. Nicole is a former director of the IRPP research program Faces of Aging, and she's the author of an IRPP study entitled Improving Drug Safety for Canadian Seniors, which we published in January. Isabelle McKenzie. Isabelle is the seniors advocate for British Columbia. She led the British Columbia's largest not-for-profit agency, Beacon Community Services, that serves 66,000 seniors. In this work, she led the implementation of a new model of dementia care that has become a national best practice and led the first safety accreditation for home care workers. She was named BC CEO of the Year for the nonprofit sector. Lex Lexton has been emergency physician at the University Health Network in Toronto for 28 years. He taught health policy at the School of Health Policy and Management at York University from 2001 to 2016, and is now Professor Emeritus at York. Joel just published last month a new book. It's called Doctors in Denial: Why Big Pharma and Canadian medical profession are too close for comfort. So I'm sure we'll have some very interesting presentations and from very different perspectives. So we'll begin with Nicole Bernier. Nicole?
Thank you, France. When it comes to prescription medicine, seniors are considered an at-risk group alongside with children, pregnant and nursing women. Seniors are the heaviest users of drugs. They take on average 7.4 drugs over the course of a year, half of which is taken incorrectly or prescribed in an excessive manner. Seniors are 5 times more likely to be hospitalized due to an adverse drug reaction. And 27,000 seniors every year are hospitalized as a result of an adverse drug reaction. That is 1 in 200 seniors. Next slide. Why are seniors at risk? Seniors respond differently to medicine. However, clinical trials tend to be done on people of younger age. So drugs are not adequately studied on seniors. Also, a lot of drugs prescribed to seniors are prescribed off-label. That is, for a condition other than what it was originally approved. This is not prohibited as such. However, a lot of 79% of drugs prescribed off-label are done without clinical trials. So there is limited evidence of their effectiveness and safety of drugs prescribed to seniors. And even when the drugs are known to present a risk to seniors, they are prescribed to them. Isabel will talk a little bit later about the use of antipsychotics in nursing homes across the country. Health Canada has issued several warnings that it presents risk for seniors with dementia, and they are still prescribed in large numbers in nursing homes especially. Also, a lot of medications on the Beers list are prescribed to seniors. The Beers list of medication to be avoided in seniors. 40% of seniors are taking a drug that is on the Beers list. Next slide. I need to say a few words about drug interactions. Seniors tend to take multiple medicine, and when they take, the more medicine they take, the more at risk they are to have an adverse drug reaction. 2/3 of seniors take 5 or more drugs. This is considered polypharmacy, and 1/4 of them take 10 and more drugs. So a lot of seniors are taking multiple drugs, and how these drugs interact, we have, again, very limited evidence, because not only seniors are excluded or tend to be excluded from clinical trials on drugs, but they also, clinical trial on drugs tend to exclude patients who take multiple drugs, such as seniors. So we have, as a result, 12% of seniors, a study has found, who are on multiple medication will require medical attention or even go to the emergency department as a result. Huge numbers. Next slide. So what are we doing across Canada to address the problem? There are several initiatives that I document in the study I wrote with the IRPP, and we find that a lot of groups are collaborating together. Doctors, pharmacists are working with advocacy group and also health authorities to come up with solutions for certain problems, such as antipsychotics in nursing homes. The type of initiatives are mainly to provide better information across the country. So, for instance, we have in the past year or so, we have seen the formation of the Canadian Deprescribing Network to encourage drug optimization in seniors patients. So providing better information, and also looking at organizational issues, such as how professionals work together, for instance, doctors and pharmacists, how they work together and how that can be improved in relation with the issue of drug safety for seniors. Next slide. There are many initiatives, but they address specific issues. They tend to address specific issue or a narrow part of the bigger issue. And what we need to do better is we need to implement a systemic change. Next slide. There is a unique role for governments, and so far governments have relied heavily on the voluntary efforts of social and professional groups, while they've been neglecting their own powers. The governments have unique powers. They are the only ones in a position to enact and enforce legislation, and also to provide financial incentives and disincentives to encourage or discourage certain prescribing behaviors. So they can steer much better the collective efforts in the country and with much greater effect. Next slide. So here are a few ideas of what provincial governments could do better. For one is to extend coverage to non-drug therapies. This would provide non-drug therapies, for instance, physiotherapy, nutrition therapy, sleep therapy. There are different therapies available other than drug therapy, which is covered by provincial plans. So this would give other options to physicians when it comes to treating patients. Also, provinces could require medication reviews. Most provinces, all provinces except Quebec and Manitoba, and except also the territories, now have medication review programs. But not everyone in the country has access to regular medication review, where they can, like patients can ask pharmacists to look into the medications they're taken. And because these programs are conditional, or the patients need to correspond to certain criteria. So this could be better used, and also provinces could provide better incentives for professionals to consult with each other. For instance, in Ontario, the MedCheck program, pharmacists can consult with, who have done a medication review, can consult with a physician interested in deprescribing. So these tools could be better used. Provinces could also better support the development of clinical decision-making tools, so that professionals would have access to better and more up-to-date information. And also tools to access the full medical records of their patients. In BC, there is the PharmaNet program, which gives access to pharmacists and physicians to all the medicines that are dispensed across the province. So this is an example that could inspire other provinces as well. Next slide. So there is also, of course, a central role for the federal government. The federal government is the main regulator when it comes to prescription drugs, and Health Canada's leadership could be much more affirmative. And I will save a few comments for later on the role of federal government, because. Next slide, I will just conclude by saying that governments can do much more and much better to address this issue.
Merci, Nicole. Isabelle?
Thank you. Good morning to my colleagues in the West, good afternoon to my colleagues in the East, and good day to my colleagues in the territories. So the first slide, I'll start with legislative mandate and scope of the Office of the Seniors Advocate, just to give everybody a sense of context. This is a statutory office of government. It was created through legislation, the Seniors Advocate Act, 3 years ago. So we're just still in our early stages of building on our mandate. And our mandate is best described as 4 main functions in 5 key areas. So we monitor the provision of services to seniors, we analyze systemic issues, We provide information and referral to seniors and their families, and we provide reports to the minister responsible for seniors. At the moment, that's the Minister of Health. At the moment, it's still actually Terry Lake, who it's going to be tomorrow, or the next day is all a big mystery in BC at the moment. And we provide recommendations to the minister and service providers on how to improve services to seniors. We cover 5 areas. It's not just healthcare. Healthcare is a big part of the work we do, but we look at the broader determinants of health as well. And so we're legislated to look at housing, income supports, personal supports, and transportation. So that's just a bit of a quick overview of the office. Next slide. So what the Office of the Seniors Advocate has been monitoring in our report that impacts our presentation today is that we do 2 key reports a year. We produce an annual monitoring report, and we have a residential care quick facts directory that gives information on each of our care facilities. And so we are looking at the use of antipsychotics without a diagnosis of psychosis, which CIHI has put out as a quality indicator. We are also monitoring the use of antidepressants relative to the population diagnosed with clinical depression. We track medications with adverse events. We have reached out to our home care population, our home support clients, and we have surveyed them about drug use. We do not have good critical incident reporting mechanisms in home support the way we do in residential care, so we are relying more on a self-reporting system. And we are currently in the end stage of a massive residential care survey of all of our publicly funded facilities in British Columbia, 300 in total, asking a multitude of questions about quality of life, but we also asked some very specific questions about their medication. Next slide, please. So based on all of this monitoring and information gathering, what are the areas of concern to my office around medications? We have concerns in many areas, but I'm going to restrict my comments today to the topic of medications. So first and foremost, and Nicole touched on this, is the use of antipsychotic in residential care. Now, British Columbia, for whatever reason, actually is one of the poorest performers relative to other jurisdictions in Canada. So our trend line is going in the right direction. It is going down, but our absolute numbers and the rate of decline is worse than other jurisdictions in Canada. So based on the latest CIHI data, we show 28% of our residents in care are on an antipsychotic without a diagnosis to support that medication. Compared to, for example, Alberta is at about 18%, Manitoba is around 20%, Ontario is around 24%, and the national average does land around that Ontario number of 24%. So we are not doing as good a job in Canada, or in British Columbia, pardon me, as the rest of Canada is doing on this. So we've drilled down and done some analysis, and one of the things we do have in British Columbia is we do have very robust pharmacare data because of our programs here. And so we looked at the admission process to residential care. We are able to track what medications people were on in the community and then what medications they were prescribed once they went into residential care. And what we found is that 32% of people who were admitted to residential care with no history of an antipsychotic in the community received an antipsychotic prescription within 6 months of admission to residential care, and 70% of those were actually within the first 7 days of admission, which basically means upon admission. So we are making, when we are doing our assessment to bring someone into care and we're looking at the medications, we're putting them on an antipsychotic. One of the big issues, as any practitioners out there will know, is orders are often issued PRN, which means a physician has said, use this medication if and when needed, as opposed to a very prescribed regime of when the medications should be administered. And so this does leave out there some questions about, okay, what has fundamentally changed that has required these folks to be put on antipsychotics? And we're continuing to look at these data to see the duration of the antipsychotic and whether or not a review would result in removing somebody from antipsychotic drug orders. Next slide, please. Since although this is not used as a QI by CIHI, I do believe it is an issue when we look at 24% of the population in residential care diagnosed with depression, 50% of the population on antidepressants in residential care. So again, we drilled down and we found that 29% of people with no history of an antidepressant being used in the community received an antidepressant within 6 months of admission, 52% of these within 7 days of admission. So what I am very concerned about, and Nicole talked about the off-label use of some of these drugs. My colleagues will tell me, well, you know, we're not using them for depression, we're using them for sleep aids, we're using them on PRN orders, to which their response is that's not the intended purpose of these drugs. And Nicole has pointed out, and I think Joel will follow up with, how we just do not have any data to support the impact of these medications on seniors' slower metabolism rate, on the polypharmacy that they on average have versus the population at large where the drug trials are taking place. So we're very concerned about the use of antidepressants. Next slide, please. And benzodiazepines. So Nicole talked about the Beers list. Benzodiazepine use, which is, for want of a better term, a tranquilizer, an anti-anxiety type of drug, a Xanax, a Valium. They're counterindicated for the elderly population. And yet 37% of people with no history of benzodiazepine received the benzodiazepine within 6 months of admission to the care facility, 66% of these within the first 7 days of admission, which means basically upon admission. And you know, it's interesting, one of the stated purposes of a benzodiazepine, obviously anxiety, panic disorders, sleep disorders, this type of thing, but also we will administer it before surgery to induce relaxation and amnesia, interestingly enough, because of course we do, there are circumstances, in fact, where we think it will be better if the person doesn't have full memory of some of the trauma that they may be. So that's an interesting use of a drug that we are prescribing on a seniors population, where issues around cognition and memory actually are paramount. Next slide, please. Opioid poisoning. Now, Nicole talked a lot about adverse drug reaction, hospitalization from adverse drug reactions. This is focused specifically on opioid poisoning, and this was a CAI study. And I've chosen this one because I think it illustrates that in the world at large at the moment, particularly in British Columbia, so lesser in other parts of the country, although it's starting to ramp up in Ontario, there is a very clear lens put on the issue of opioid overdoses and the focus on the mental health and the street community and the use of these opioids. Interestingly enough, seniors have the highest rate of opioid poisoning of all age groups in Canada. So as you can see, 65 plus, 20 hospitalizations per 100,000 for opioid poisoning, not just an adverse drug reaction, versus in the 24 to 44 age group, where you think that's where most of it's happening. Actually, the rate's only 13.1% admission. And then we know that when admitted for opioid poisoning, the length of stay that follows in the hospital is much longer for our seniors as well. And we also know that when a senior presents at emergency because of opioid poisoning, the reason for that poisoning is linked to therapeutic use and mismedication, as opposed to in younger groups, it's transposed, where in fact the majority of them have self-administered the drug consciously. And so when you're looking at where can we have an effect in terms of prevention, certainly ensuring that the drugs are being taken properly, and that the dosage is appropriate and that interactions have been accounted for, could significantly reduce opioid poisoning amongst our seniors. Next slide, please. So we did a survey of all of our home support clients in British Columbia. We have about, at any given time, about 28,000 clients on home support. We asked them a whole bunch of questions about their home support, but we also wanted to ask them about their medications, because this was a group of people, I think, that represented part of the key demographic within seniors that we're looking at when we're looking at the issues of polypharmacy. So we asked clients if they knew how many medications they were taking. We asked them if they knew what they were taking them for, and we asked if they knew the side effects of them. So actually a good number reported that they did know how many medications they were taking. 12% didn't know how many they were taking, but 88% did know how many they were taking. Less than 60% know why they're taking all their medications. But one of the things that stood out was less than 20% know the side effects of the medications. And this is very important, because many of the side effects of some of the medications people may be ascribing to some of the conditions of aging and not paying attention, not reporting to their physician, not reporting to the nurse in the care home, and families not reporting some of these side effects, confusion, lethargy, that in fact are a response to the drug, not simply part of the aging process. Next slide, please. So, raising further questions, need to better understand. We need to look at the role of the hospitals in prescribing medications to seniors prior to entry to residential care. So one of the things that the care homes will say in response to the data I have put out there, well, they come to us from the hospital on that medication, so it's not reflected in their community use. So they went into hospital not using the medication. They were prescribed the medication in the hospital, which is more difficult for us to track for a variety of reasons. So when they go to the care home, it reports as they were prescribed within 7 days. They never had it before, but in fact they came from the hospital. So we need to drill down a little bit and look at what is happening in the hospital setting, what is being prescribed, and why is that carrying on into the residential care home. We need to look at the drivers of medication prescription within residential care. Nicole touched on it a bit around alternative therapies to medications. So we're looking at, can anxiety be relieved by more proactive involvement of care staff? Can anxiety be relieved by looking at the triggers of that anxiety in the resident and modifying either their environment or their routine in order to diffuse that anxiety? Sleep management, and I mean, this is anybody out there who's delivered care is going to understand this balance between some of the challenges around medications, but also challenges around the symptoms or the conditions that are presenting in the senior that we want to find a way to treat. And sleep deprivation is a tricky one. At the end of the day, sleep deprivation is not good for seniors either, and there's a whole multiplicity of symptoms that will present from sleep deprivation, and so this balance around the lesser of two evils. But I think that those of us who've delivered care would also acknowledge we have probably not fully pushed the envelope yet on how we can deal with sleep disorders in a care facility using a non-pharmacological intervention, whether that's adaptations of routines during the day, whether it's recognition of different sleep patterns. I think we could do a lot more. Family pressure is another thing that we have to acknowledge. Certainly those of us who've been in care certainly know, my mom's upset, what can we do to calm her down? Mom's depressed, what can we do to get her more energetic? My mother complains she's not sleeping. And so we are reacting to that to some extent as well. And so we have to have better conversations with family members. Next slide. So what can we do? I think this webinar, the work of IRPP, the work of CIHI, the work of offices like mine around highlighting the issues through public reporting is how we start to change. Everybody, I'm sure, can reflect back 25 years ago around things where conversations were beginning, and in fact, we've made great gains today. And I think that drug use amongst seniors, particularly in residential care, is one of those issues where 10 years from now we'll look back and we'll see we've made progress. We need to share facility level and provider level data with health authorities, with facilities, and with care providers. You need to measure, you need to report before you can begin to manage. And we're getting there as well. Certainly the RAI data is helpful. More analysis of the drivers of prescribing behavior. We need to look at physicians' prescribing behavior. We need to look at outliers. We need to find out what is happening and just pay more attention to this population. Identify and promote non-medication interventions. Nicole touched on that. I've referenced that. And better education of seniors about medication use and healthcare across the continuum. Next slide. So what is the future work that my office is doing? We're actually sitting on an advisory healthcare consent panel looking at consent for a number of things, including medication. So it's an interesting question. We're wrapping up the province-wide survey of all of our care facilities. We did ask questions about medication in that survey, and we did, consent is one of the questions that I think will be highlighted to show that seniors certainly don't feel they're being adequately consulted about the medications that they're taking in the residential care setting. So I think with all of that work and the attention we're focusing on it, I think that with persistence and consistency, we will improve where we are today. Thank you.
Thank you, Isabel. Joel?
Thank you very much. It's a pleasure to be able to participate in this webinar. So Isabel and Nicole have discussed the issues specifically related to seniors, and I'm going to take a step back and talk about how Health Canada deals with drug safety in general. So next slide, please. And I have no conflicts to declare. Next slide, please. So I'm going to cover 5 points very quickly. Nicole has already spoken about the limitations of pre-market clinical trials. There's also an issue around how quickly drugs are approved. Those are called priority approvals. I want to talk about how Health Canada distributes its resources between getting drugs on the market and monitoring their safety once they're already on the market. Something about post-market clinical trials, how drugs are withdrawn and what we know about the reasons why they're withdrawn, and finally, Health Canada's communication processes around drug safety. Next slide, please. So Nicole already dealt with the problems with pre-market clinical trials. This slide just illustrates that point with a graphic showing that the number of potential people who could enter a trial and the number that finally do enter is much smaller because of a variety of exclusions: elderly, people on multiple medications, women. Next slide, please. And those clinical trials that are actually done are usually ones with relatively small numbers of people, and they're also trials that go on for relatively short periods of time, even though some of these drugs are going to be used over long periods of time. So trials will last for 6 months when drugs are meant to be taken for the rest of somebody's life. So the result of this is that when drugs come on the market, we know relatively little about their safety, aside from the small group, relatively homogeneous people that they've been tested in. So for everybody else, it's somewhat of an experiment exactly what's going to happen when they're exposed to these medications. Next slide, please. So this slide illustrates the difference in post-market safety depending on how a drug is approved by Health Canada. And so we can see here, Health Canada has 2 main approval mechanisms. There's the standard mechanism, which takes 300 days, and then a priority mechanism, which takes 180 days. And what this graph shows is that if a drug goes through the standard process, it has a 1 in 5 chance of there being a serious safety problem identified once the drug is on the market. If it goes through the priority process, which takes 180 days, there's a 1 in 3 chance of a serious safety issue. And this difference in post-market safety is not due to either the condition that the drug is treating or how the drug or the mechanism of action of the drug. It's primarily due to the length of time that Health Canada takes to do the review. Faster reviews seem to result in safety issues being overlooked. And that means that once people are exposed to the drugs when they're on the market, they're running risks that are unknown. Next slide, please. Health Canada's focus seems to be on getting drugs onto the market quickly rather than monitoring their safety once they're available. So if you just look at the information for the fiscal year ending March 2010, what you can see is that the first 2 directorates, that's the Therapeutic Products Directorate and the Biologic and Genetic Therapies Directorate, the ones that are charged with approving new drugs, get roughly 3 to 3.5 times more money and more resources than the Marketed Health Products Directorate. That's the part of Health Canada that monitors the safety of medications once they're already on the market. Next slide, please. Health Canada does have a mechanism also for approving drugs based on limited information of compliance with conditions. And in order for a company to utilize this pathway, they have to promise that once the drug is approved, that they will undertake further trials to both establish definitively that the drug is effective and also to look at unresolved safety issues. And when you look at this, you can see that for a number of drugs, it takes more than 6 years before these conditions were fulfilled. And we have drugs on the market that have been available for more than 6 years, and in some cases more than 10 years without these conditions being fulfilled, which means that when doctors like me are prescribing these medications, we don't know if they're really going to work, and we don't know if how safe they really are. And the reason why these trials are delayed so long is not made clear by Health Canada. Next slide, please. So this slide deals with drugs that have had to be removed from the market completely because of safety issues. And they're divided into 3 categories. So the first 2 drugs were pulled from the market had serious safety warnings issued within 20 days of approval. We don't know why that occurred. What happened in those 20 days between when Health Canada thought a drug was able to be marketed and when it had to issue a serious safety warning. For another group of drugs, these ones had a safety warning issued and then were pulled from the market between 1 and 2 months after that warning was issued. Again, what changed to go from be careful when you're using this product to don't use this product at all, it's too dangerous, the information is lacking. And finally, there's a group of drugs that were pulled from the market without any previous serious safety warning, and we don't know why that happened either. So there's a clear dearth of information coming from Health Canada around drug safety for drugs that eventually are removed from the market completely. Next slide, please. So this again touches on a theme that Nicole raised around the question of prescribing of antipsychotics to people who are living in long-term care facilities. And what we can, this looks at changes in prescribing rates when warnings were issued. And what we can see from this is that instead of prescribing actually going down when these warnings were issued, and these warnings were about increased deaths in people who were prescribed these products. So instead of prescribing actually declining following the warnings, initially there was no effect of the warnings on prescribing rates. They kept going up. And eventually, after the third warning, prescribing seems to have leveled off, but not actually declined. Next slide, please. So, in summary then, when it comes to the way that Health Canada deals with drug safety, pre-market information is limited because of the design of the clinical trials. The post-market surveillance system is not adequately resourced. The latest data I can find says that it gets 1/3 of the number of people and 1/3 the amount of money that's given to the parts of Health Canada that get drugs approved. Drug safety withdrawals for safety raises questions about how Health Canada evaluates the safety. It doesn't communicate that information to either the public or to clinicians. And finally, when Health Canada does communicate, those communications may not be effective in changing the way that doctors prescribe medications. I think that there are things that can be done around all of these issues, and I'll be happy to answer any questions related to that that the audience may have. Thank you very much.
Thank you, Joel. So we've already have a number of questions from some of the viewers, and we welcome more. I have a first question for Isabel, and the viewer asked: have you looked at whether the residential homes are doing medication reviews with in-house pharmacists quarterly to pick up meds that may not be needed anymore?
The short answer is we've not monitored that in a systemic way. It's a good idea, and to see whether there's any correlation between that and utilization. We do in British Columbia, in our fee code for physicians, do allow for billing for medication reconciliation or medication reviews. But that's a good idea actually for us to look at.
And Joel, you spoke about the priority reviews, and one of the announcements that was made by Health Canada last month is providing faster access to safe and effective prescriptions, and that involved expanding the priority review process to better respond to the needs of Canadians. And one of our viewers asking why is there a priority review if the risks are greater?
Well, there are a couple of issues that this question raises. So the first one is that the identification that the safety issues are greater with priority reviews was based on an analysis that I did. I'm not aware that Health Canada ever actually looked into that issue. If it did, it never made that information public. Second point is that priority reviews to allow drugs that provide significant new therapeutic benefits to get to the market quicker. But in fact, when you analyze the drugs that Health Canada gives these priority reviews to, and you look at how much of a therapeutic advance they actually are, Health Canada does a particularly poor job of being able to identify which drugs should actually get a priority review. So currently, Health Canada is giving priority reviews to about 1 in 4 drugs. But when you look at the objective evidence of whether or not those drugs are a major therapeutic gain, it turns out that it's about 1 in 10 that offer that advantage. So Health Canada is doing priority reviews on a lot more drugs than it should be.
Thank you. Nicole, you know, the last announcement in May that the federal government is intending on working with partners and stakeholders to develop policies and tools for appropriate prescribing. In your paper, you list a number of policy options or measures that would help improve the situation. Can you tell us what would be your priority measures in that regard?
Yes, although the Health Canada has announced that it is an important issue to improve appropriate prescribing for the general population, it also emphasizes the importance of reducing costs and also for medicines, and also to have faster reviews. So it will be interesting to see how the tension between faster reviews and appropriate prescribing will be solved. This is not something that is available in the document issued by Health Canada, but it's very relevant, and Joel has provided a lot of data to show that it is an issue. There is a tension between the two goals. Health Canada, I will shortly just review a few things that Joel has already covered. So I think I want to bring one fact, which is important. Health Canada doesn't tools to exert the leadership that is expected of it sometimes. For instance, it is interesting to know that until 2004, before the Food and Drugs Act was amended, Health Canada didn't have the power to recall a drug from the market without negotiating with the company that is marketing the drug. So only a couple of years ago did they gain these powers. So there are a lot of powers that are not within the available to Health Canada to properly execute its role. Important to reinforce clinical trials, and if a drug is to be used mainly by seniors, it would make sense that it would be tested on seniors before it's put on the market. Also, same point as Joel covered, monitor drugs that are already on the market, including label drugs prescribed off-label to seniors are doing, and long-term use. What do we know about this? And then, of course, report how Health Canada handles the reporting on adverse drug reactions, and how it reports back to the community is of central importance.
Isabel, Joel, do you have any comments on this?
Joel, I'll let you go first.
I think that Nicole is correct, that Health Canada has a lot of more power than it's chosen to exercise. And in some areas, Health Canada has decided not to get involved. So many other countries, the federal governments are involved with directly with providing resources to help doctors improve prescribing behavior and help patients improve the way that they use medications. So in Australia, which is also a federal country like Canada, the federal government there funds the National Prescribing Service to the tune of $50 million a year. The National Prescribing Service is run independently, and its job is to run programs for both doctors and patients to make sure that the drugs are being, they're getting the best value in terms of their health from the medications. Health Canada has never done anything like that.
So here in British Columbia, we have another layer because we effectively have in British Columbia universal drug coverage. So in most provinces, seniors' drugs are covered, but in many provinces, the rest of the population is not covered. In British Columbia, everybody is covered. And so as a consequence of that, BC has developed a fairly robust oversight system of what drugs get put on the formulary. We have a therapeutics initiative, which reviews another layer of review from at the national level. And all of this is a convoluted way of saying, while I agree with Nicole and Joel that Health Canada could be doing more, I think the challenge is simply the structure of Canada, where it is a system of systems, right? So what is at the federal level and what is at the provincial level? You referenced Australia, and I was just in meetings yesterday around assistive technologies and some of the things that Australia has done at a national level. But it's much more a cohesive country around health policy in Australia than we are in Canada. And so that is, I think, a structural impediment to having Health Canada realize its full potential. If we were to move to a national drug program, actually that may be the impetus to start and look at a more pan-Canadian approach to some of these issues around medications and drugs.
Another question from a viewer. Is there any research on drug interactions or overuse with respect to older adults living with dementia and or Alzheimer's disease? I guess Joel or Isabel?
As far as I'm aware, these groups tend to be left out of the pre-market trials. So if you're going to identify issues in these groups, it's once the drugs are already on the market, and that depends on how robust the systems are for collecting data. So the best estimate, or the estimate is that at best about 10% of adverse drug reactions are actually reported. So we don't often have a good amount of information about these issues. When it comes to emergency departments, where I work, there's data out of British Columbia that shows that we, emergency doctors, miss about 50% of the adverse reactions that bring people to hospital.
I would say I agree with the underreporting, in part because of what I referenced earlier, that some of the side effects or reactions to these drugs are masked by either the patient taking the drug or the family member around the patient ascribe those reactions to, in fact, the process of aging. So I go back to our home support survey, where high reporting of people, yes, I know what medications I'm on, yes, I know why I'm taking them, no, I don't know what the side effects are. So if we aren't educating patients, particularly seniors and their family members or their caregivers, their professional caregivers, about the side effects of these medications, we're going to continue to have significant underreporting.
Speaking of, so, Joel, if drugs are only tested on a narrow range of patients, what could clinicians do once those drugs are on the market?
Well, I think that there are a number of things that we can start to do. Some of them are very inexpensive, so we could follow up. This isn't apply to doctors, but in the UK and now throughout Europe, when a new drug comes on the market, all of the material associated with that drug has an inverted black triangle on it. That inverted black triangle says, this drug is new. We don't know very much about how safe it is. If anything happens, either tell your doctor so that they can file an adverse reaction report, or file one yourself. So that's a simple thing we can do. When it comes to doctors, I think that we need to recognize that there are very few drugs that come on the market that actually make a difference to the people we treat in the majority of cases, and that if we're going to prescribe a new medication where the information is limited, that we have to be very clear why we're doing that. In other words, we have to, one, have done our reading about the medication, and two, make sure that that medication really is the most appropriate for the patients we're seeing, rather than prescribing it because it's being heavily promoted.
Nicole, one of the issues that comes out in your paper is the whole reporting of adverse drug reactions. Can you tell us a little bit more about that? I mean, it doesn't seem to be mentioned in the latest announcement by Health Canada. So who takes the responsibility to get that in better shape?
Yes, it's a complex issue. It's not easy to report, for clinicians to report on. It's not easy to identify drug reactions, and also it's not easy to get information on drug reactions. So for sure, better systems can be developed. Areas that should be considered is that the Minister of Health could do the same thing it did a few years ago in the case of therapeutic products for children, which was to the Council of Academies to look into the issues. So this would involve providing an assessment of drug safety. So really look into the gray zones, because there's a lot of things that we don't know about reporting, but also how the medications are doing and so on. So we would have a panel of experts who look into the issues with some detail, perhaps look into other jurisdictions, what is done and what could be applicable to Canada to improve the situation.
And Isabelle, I mean, your group publishes public reports, and some of the issues that you raise are really systemic issues, it appears, and very disconcerting. So what type of reaction are you getting, both from the broader public when you release these reports, and any feedback from the government on actions moving forward?
Well, I think certainly the public, it resonates with them when they think that our most frail and vulnerable citizens in any age group, but particularly in seniors, are not receiving optimal care, and particularly around this issue of prescribing, of polypharmacy, the antipsychotics, the antidepressants, particularly in residential care. I think the government's response, certainly the government that has been in power, walks a fine line between regulatory oversight and regulatory overreach, and that is a balance. But I think that what is revealing itself as we go through these systemic reviews is that perhaps we do need a little more oversight, because not in a pejorative way that care homes aren't doing what they're supposed to be doing, but we pay attention to what is monitored, rightly or wrongly. And so I think tighter monitoring of medications, particularly these PRN medications, looking at whether we incorporate quarterly. At the moment, we only have annual care reviews. You could ask about the efficacy of that when the average length of stay is just slightly over a year, and how we embed that into practice in our care facilities. And then it links to money, right, to the staffing costs around the oversight that we need.
Thank you. We only have less than 2 minutes left. In 20 seconds, Joel and Nicole, any last minute message you want to leave us with? Joel?
In terms of long-term care and the way that medications are being used, I think that a lot of times, and this is one of the questions that came up, was whether or not there are benefits from them. And sometimes from the antipsychotics, and sometimes there are, but there are also problems with the antipsychotics are being used because of staffing levels in nursing homes, that the staffing levels are low enough that the people who are on duty, especially at nighttime, feel that their workload could not be managed unless people were being medicated so that they were able to sleep and not wandering around. So I think one of the things we need to look at is the way that we're funding long-term care facilities.
Nicole?
My comment will be very brief, only to end in saying that we have been looking at seniors, issues for drug safety in seniors, but they're not an at-risk group, but they're relatively at risk, more at risk than the general population. So by improving the processes, as I think we should do, we are improving things for everybody.
Thank you.
Everybody is taking medication.
Thank you, Nicole. This is all the time we have for today, and so I want to thank our panelists for their excellent presentations and all of the participants for taking part in the discussion. The event will be posted on our website, and you will be receiving a message asking for your feedback on this webinar. So thank you so much, all of you, for joining us, and on behalf of the IRPP, thank you and have a nice day. Thank you.
Thank you.